I think we're going to get started because we have two presenters this afternoon, and we want to give them all the time that is needed so that they can share with us some vital information that they have either researched or been a part of. My name is Vera Lane Brown, and again, welcome, and I hope you've had a good morning and a good luncheon session during the first part of the conference. I will be the moderator and to facilitate things that will take place in our session today. I want to make sure before we get started that you turn your cell phones off or turn them down so that we will give our presenters the most and wholeheartedly respect that they need while they're presenting. And if you have to leave, just please leave it, and if you don't mind, leave it quietly. I'd like to remind you that there will be an evaluation, not at the end of the session, but there will be an evaluation emailed to you on May 15th. So once you get your evaluation, will you please complete your evaluation and hit the button sent so they will come back. Also, we like information to provide us with feedback so that we will know how to improve next time around. As I said, we have two dynamic speakers, and we heard one person stand and speak this morning to a couple of questions or to a question. But I'd like to just do the honor of providing just a brief piece of information about them, and then I'll turn it over into their hands so that they can begin their presentation with you. First of all, I would like to introduce Dr. Anita Gaylord, who joined the staff of the Tobacco Prevention and Cessation Commission of the Indiana State Department of Health in July 2001 as the Director of Community Programs. In 2003, Anita was named a fellow in the prestigious Robert Wood Johnson Developing Leadership Reducing Substance Abuse Program. Mrs. Gaylord holds a Master's of Science in Public Health degree from O'Hara Medical College and a BA from Fisk University. She will share more information about herself as she presents. Our next speaker will be Dr. Takeda Freeman Ferguson. Dr. Ferguson is an assistant professor of epidemiology at Louisiana State University Health Sciences Center, the School of Public Health in New Orleans, Louisiana. She is an investigator for the Louisiana Tumor Registry and the Louisiana State University Improving Clinical Outcomes Network. She also earned her Master's of Public Health in Health Education Communication from Tulane University, School of Public Health and Tropical from Tulane University School of Public Health and Epidemiology and Prevention of Cardiovascular Disease, Tahoe Fellow in 2009. That's a long name, okay. As Dr. Ferguson begins to speak, she will share more information about herself as well. So I'll just take my seat and turn you over into the hands of Mrs. Anita.
Am I okay not using the mic? I know
Yes.
You can hear me, but is it okay for the video? Okay. So I wanted to first tell you that I am Community Programs Director of Community Programs, and that's what I do. So I'm a program person. This presentation was actually submitted by one of our evaluators, and then she got a new job, and so then I've been dispatched to come do the presentation. So if I can answer the questions about data so well, I can get back with you because I'm more of a program person. And she told me, just be honest and just tell them that at the beginning. So no excuses, but a lot of my background comes from the program side of it. But what we would be looking at in Indiana is what's happening with our young African-American youth when it comes to tobacco use, and that's what we're presenting to you today. The irony is it was everybody in Dr. Gardner's presentation this morning. Okay, Indiana is classic, from what I understand based on what he said, meaning we're a lot like what he talked about. There were very few things that differentiate us from what he talked about today. So I'm going to present the data to show you that. And then we don't have a solution in this presentation. We haven't given you a solution, so we want to spend a little time talking about what we can do. So we called it the Deadly Unexplained Freedom, the increased tobacco use with age among African Americans in Indiana, because something happens in Indiana, which it sounds like it happens all over the country when it comes to using tobacco products, and that's what we're going to talk about today. I guess they put this in my presentation, but I have no affiliations with or commercial interests. I had to sign a form, and I guess they put that in my presentation. Okay, so the objectives. The objectives are, I'm going to talk to you about the smoking rates between African American youth and adults, and then we're going to analyze, and you've heard a lot about menthol. I was in the menthol presentation before coming in here, so you've already heard a lot about menthol. But you can hear about menthol in the state of Indiana, and specifically about Black and Mild, Swisher Sweets, and Philly's Blunts, which I think are the ones that we've been talking about in the other presentations too. And what we found out in the state of Indiana about what happens when we talk to African Americans about branding. What's happening earlier? Okay. And then we're going to talk a lot about, well, not a lot, we don't have a lot of time, we're going to talk about marketing, and that again has been talked about in some of the other presentations, as well as review some of the data in Indiana about attempts to quit smoking, and then talk about cultural protective factors, which is the part that I really am going to need you to participate in the discussion, because we're going to get to the point where we say, well, what in the world is happening? What's going on? What can we do to make a difference? How can we make this, how can we change this? And this is our data source in Indiana. We're using the Indiana Adult Tobacco Survey and the Indiana Youth Tobacco Survey. And we decided upon these two sources because that's the survey information, the data in Indiana, that also gets at attitudes and beliefs. So we didn't want to use different types of different sources of data to bring this presentation to you. So we decided on just using the ATS, the IATS, and the IYTS, because that data also transfers into attitudes and beliefs, so we can be consistent with the population that we're using. So just so you know, that's where this information is coming from. Okay, so here's the problem. African American adults have a higher smoking rate in the state of Indiana than Caucasians. Nothing new, right? Or is it different in your states? That's about right, isn't it? Okay, that's about right. You can see the rates there. And we think this reflects what's going on in the country. 25% for African Americans versus 19% for Caucasians. And this is what Dr. Gardner said earlier, but what happens? We smoke fewer cigarettes. We consume fewer cigarettes than Caucasians, 10 per day versus 19 per day. So even though we have a higher smoking rate, we still have a lower consumption rate. We smoke fewer cigarettes per day. So you have to keep that in mind, and we talked about it already at this conference, because it does have an effect on the outcome. Okay? But the same thing is true for Indiana. Now let's take a look at our students. Our African American high school students report smoking less. Report an 8.6 rate versus 14.5 with Caucasians. So our kids smoke less than Caucasian counterparts. But here's what we found out. And you see two sets of numbers there. So the first set, the 19% for African Americans versus the 11% for Caucasians, is when we specifically asked them not just about cigars, but we specifically asked them about brands. And we mentioned the brands. We mentioned the Black and Milds, the Swisher Sweets, and the Philly Blunts. So they say then they've smoked, current smokers at 19%, that means they've smoked it at least one time during the last 30 days. If we just ask them about cigars, and that's the word we use, cigars, then it goes down to 13%. This is the African American number, 13% versus 11%. So you see what we're trying to show you, the difference? So they'll report a lower use of cigars when you don't mention the brand. So I'm not exactly sure what's happening there. I guess they don't know that that's what we mean when we say cigar. They don't consider that product a cigar. But then when we specifically mention the product, then the number goes up. So we know that they're smoking more. And it's a pretty significant number. If you look at cigarette smoking in high school, the 8.6 versus the cigar at 19 or even 13%. So we know we have a problem with the other tobacco products in the state of Indiana. And this is just another way of looking at it. We just thought we would present a graph so you could see the high school smoking rate, and we added the Latino smoking rate in the state of Indiana, which is very close to the African American smoking rate when it comes to high school age, and then you can see the middle school. So there's a significant jump from middle school, and then I'm going to show you what happens after that. 90%. Any ideas on what that represents? Pardon me? 90% of adult smokers who smoke
Before 18.
No. Menthol. Menthol in Indiana. 90%, you're close, of adult smokers smoke menthol cigarettes in the state of Indiana. I heard in this last one, it was 80%, I think, across the country. 90% in the state of Indiana, and we've been able to get this information from the 2013 Indiana adult smoking rate. The 2013 Indiana adult smoking rate found that 90% of African American adult smokers use menthol cigarettes. So we have a problem in Indiana. And part of the problem that we have in Indiana is that we are preempted for doing work in the retail arena, meaning you've heard of preemption, the concept of preemption. For instance, in tobacco control, some states are preempted from passing local smoke-free air laws because they have to go by whatever the state says. And the state law has something in it that stops them from being able to do that at the local level. Well, in the state of Indiana, we're preempted for retail work. From the way the law says it is, from the display, distribution, and sale of tobacco products at the retail level. So we cannot pass ordinances in our communities that are stricter than what the state law says when it comes to the retail setting. So maybe one of the reasons, so we would not be able to, in the state of Indiana, pass an ordinance in Indianapolis like Chicago did, that we just heard about. Chicago passed a ban where they have to be 500 feet. The stores have to be 500, if they're 500 feet close to the schools, and they can't sell flavored products. We can't do that in Indiana because we're preempted by state law from passing stronger local laws than what the state says. So that may be part of the problem in the state of Indiana, is we just are unable to do a lot of work at the local level. And so our storefronts have lots of advertising, which yours probably do too, but maybe you can do something about it. There is a difference between the advertising in the African American community, the Latino community, the inner city community versus the suburban communities. We already know that, and Indiana's no different from that. We know, we talked about this in the other one, that magazine advertising in our community for our people is, this backwoods, she spends a lot of money doing that. So the same things are true in the state of Indiana. We smoke a lot of menthol, and I offer to you, as we've said all along, that I'm sure the targeted marketing has something to do with that. So Indiana's no different, a little higher. Now Indiana does have a high smoking rate. I should probably put a pin here and tell you that. I've been doing tobacco control for a long time, and I never know how to say this because in the state of Indiana, we've been in the, I don't know whether to say the top 10 or the bottom 10, but we've had a high smoking rate, so we've been in the, it seems like, when you say top 10, that sounds like it's good, but we've been in the bottom 10 with the high smoking rate for 20, 25 years. So in general, the state of Indiana has a 24% smoking rate, which is a high adult smoking rate. So we've had a problem in the state of Indiana for quite some time. So we do know we have a problem in the African American community with menthol. So here's more about the problem. And we have been able to, through the Indiana Adult and the Indiana Youth Tobacco Survey, check on quit attempts. We have, of course, the Indiana Tobacco Quit Line. Everybody has quit lines. And what we know is that more African American adult current smokers attempt to quit than Caucasians, 53% versus 43%. But the success rate is so much lower for African Americans, 3% versus 13%. Any ideas on why that is? We want to quit, and we know we want to quit, but we have a difficult time. We've talked about some of this already at this conference. What do you think?
Because of genetics, maybe?
Genetics. And you, I don't want to put words in your mouth, but you may be, what we learned this morning, or what we relearned this morning, is that the way nicotine metabolizes in our body is different, so our addictions are different, so quitting is seemingly harder for us biologically, maybe psychologically as well. What were you thinking?
They don't utilize resources
Hesitancy to use resources. Okay. Other ideas?
And I'm also thinking with menthol,
Mm-hmm.
more prevalent in African American culture.
Right. And the menthol is more prevalent. We've already established that, right? And we know that menthol it just does something to our body and it makes it harder to quit.
and also lack of healthcare services, and basically lack of education.
Mm-hmm.
Unavailable resources.
And available resources. Yep. So all of those, we can show where we make the attempt, but we haven't been successful. You want to say something?
Oh, more triggers. Just
More
reminders.
triggers. Right. Our lifestyle, or stress and other things that are going on, or in our life might be that. Okay. So yeah, there are a lot of reasons why I think that we can put our finger on. But let's think for a moment about solutions. What can we do to change this? In Indiana, we've been working harder to provide a 1-800-QUIT-NOW message to the African American community that resonates more with us. So that we'll pick up the phone, or we'll go online and we'll get the resources we need. So we've been doing some of that, and we've also been doing some of the face-to-face, one-on-one types of things that tends to be more successful in the ethnic communities, where I'm responsible for coalitions that are actually organized in each one of the counties in the state of Indiana, and we have our coalition coordinators doing more things on the ground to promote the 1-800-QUIT-NOW line in the African American community. In Indiana, it's the Latino, Hispanic community, and the African American community, so we've been concentrating on that. Any other ideas about how we can close this gap? Yes.
Well, I'm not sure the follow-up with them calling, if you have more African Americans calling, but fewer of them actually quitting, what's happening, investigating what's happening between that call and the follow-ups, and, seeing it through.
Yeah, and see, with the quit line, in Indiana at least, I don't know if it's true for the other states, we don't really ever know if the quit is a final quit for each individual. So we have a basic number that says this is the basic quit success for everybody, but we don't follow a person through to the quit. So I can't answer your question is what I'm saying, but what we know is that we try to measure quit attempts. That means they made the phone call to the quit line and they enrolled, so they're getting some help. And I don't have the data in my head, so I don't know for sure. But I think you have to believe that once they make the call and they ask for the help and they start getting the help, that it'll at least enhance their quit attempt. Any other ideas? But we know that's a problem. So let me summarize this section with the characteristics of the African American smoker in Indiana. Late initiation, and that was established earlier today, right? We start later. I know I talked to someone from Louisiana who said theirs doesn't show up like that, but it does in Indiana. It's what Dr. Gardner talked about today. Less cigarette smoke, high use of menthol, more cessation attempts, and less cessation success. So, if these are the established characteristics of African American smokers in the state of Indiana, and we know that when they get to be 18 or 25 years old, they're smoking more, what's happening in between? What's going on? What can we do to change what's happening in between? So we know that these are the basic characteristics. We know that the number jumps significantly from, and I haven't even shown it to you yet, but the number jumps significantly from when they were in high school to when they're young adults in the state of Indiana. We wonder what in the world is going on. Any ideas on that? Yes.
I don't know. I'm new to the field, but I always wondered. I know we, in general, say that smoking cigarettes leads to or can lead to other types of smoking, but I've had experiences where people would smoke marijuana, like teenage boys would smoke marijuana and not smoke cigarettes. And then when they become adults, they smoke cigarettes.
Right.
Because
Yeah.
then it's legal to buy cigarettes, and not that they care about legal, but it's
Right. So what can you conjuncture from that? What's the implication? They start with marijuana, they end up addicted to tobacco. The tobacco is a legal product.
Right.
So they, in my mind, it may be just tendencies, behaviors, cultural differences, where we just get in the habit of using a tobacco, a smoking product, and then when we can't use the illegal product, we substitute with the legal product and we start using and get addicted to nicotine. Is that what you're saying?
I am, I'm just wondering if that's ever been looked at where.
It hasn't been in
marijuana is
Indiana.
actually kind of the gateway to tobacco for some people.
But that's the reason for this presentation. We noticed the difference in the smoking rate and ages, and we're trying to then examine, or at least talk about the implications of what's happening. Other ideas?
I was thinking, well, that's usually the time when young adults leave home, at 18 or 19 years old, you're no longer under your parents' control. So you can kind of do what you want to do.
And there are some studies that show that when, as a culture, especially the African American community, when we're under mama's rules and we're at home and we're doing what we're supposed to do, we tend not to bother with tobacco products, but then when we're empowered to make the decisions on our own and we're out and about, that we then do what we want to do. And that there's a difference between what decisions we make when we're under our parents' rule and what decisions we make once we get out of the house. And there are some studies that talk a little bit about that. The studies actually say that that parents have to work really, 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 really hard to talk to their children and talk to their high school students about not using tobacco products to come close to or to help with them making the decision later in life, which I think is just normal behavior decision-making process, but it really matters when it comes to tobacco use, that African American parents have to really talk about this because the decision to smoke comes later for the African American community, for the African American kid, and we have to make sure we really instilled that information in them early on. There's one big reason too, though, that we haven't talked about. We have, but not in here right now. What is it? That's it. That's it. What do you mean by that? That's right. That's right. The predatory marketing techniques of the tobacco industry. And I offer to you that's probably it. I mean, you can say what you want to say, but advertising and marketing works. We see a brand often enough, and we'll go out and we'll buy that brand. It works on me, it works on you, and we know we live with our young people in a society where brands are really important. When I talk to young people, oftentimes they've got the brands already, they've got them on, right? It's really easy to say, there they are. I don't really recognize all of them like I should, but they're wearing the brand. So that marketing, the techniques, and we were in the other presentation, and I always say the tobacco industry knows more about us than we know about ourselves. They have studied us for so long, and they have studied us so well. They know exactly how to present these products. They've known exactly how to present these products so that we would buy them and use them and get addicted for life. You're going to say.
I would say, I know now they have new tobacco products. I haven't heard anyone really speak on it, but like snooze, with tobacco companies trying to make you a dual use. And I know just doing presentation in Louisiana where kids know that, hey, if I can't smoke publicly, I can find something to substitute that. So when I leave school or wherever, even if I'm around mama, because they have flavors. So, hey, half the time you may think it's gum, but they probably have a tobacco product and it's designed to keep us addicted to it.
Right.
So you guys have any kind of research as opposed to,
I don't know about any, but there's probably some out there. But what we know is the tobacco industry has nicotine delivery systems. So the tobacco industry's figured out how to deliver nicotine to our system without the actual smoking behavior, and that's the products that they're spending a lot of time making, and as a result are doing. Yeah, they know about that stuff, don't they?
Where they bust it once they the little smooth package, they're busting it open to swallow it to get a quicker fix of nicotine. So I'm not sure how they would play into.
Yeah, the tobacco industry knows exactly what it's doing in order to keep us, not you and I, but to keep our society addicted to nicotine and to deliver nicotine to the body so that it depends on it, and then it buys whatever it needs to get. A person buys whatever he or she needs to get that nicotine.
It was a quote from R.J. Reynolds, I want to think, in 1998, where it said that we know the pattern of young adults and they'll be out tomorrow future regular smokers. So this was in 1998. So back then they try to figure out, they think long term.
Right.
Trying to,
Dr. Yerger showed us some slides, and I was a little fascinated by the fact that they were from 1986.
Right.
1986. But the tobacco, I always say the tobacco industry is always 10, 15, 20 years ahead of us, and And 10 years to the tobacco industry is but just a little bit of time. Just a little bit of time, because they can wait 10 years to get things done that they know they're going to get done, that have the vision for the future. So I think Dr. Gardner gave us some reasons today earlier too. Let me finish. Okay, and the implications. The bottom line is death and disease, which is the saddest part about this whole conversation. And this is the numbers for Indiana. And that is that the lung cancer mortality rate is higher among the African American community, 64.3 deaths per 100,000 versus 57.5. And the males, you see that number for the men? This is Indiana, remember, but for the men in Indiana, it's kind of scary. So, and Dr. Gardner, this is where Dr. Gardner did suggest some reasons that this might be: late diagnosis, burden of nicotine on our body, health literacy, or maybe we're afraid to enter into the healthcare system. But we know that even though we start later and we smoke less, what do? We die more. And our men are dying from lung cancer at a higher rate in the state of Indiana than we even would like to talk about. Is that true for other states?
Yes.
Okay. So let me conclude with just a few suggestions. And our suggestions in the state of Indiana have to do with policy. Is that consistent with your state's policy? You know, we talked about education and even the media. Those are all good components of the tobacco control program. But what we're suggesting here is that some policy is going to make a difference. Ban on menthol, we've heard all about that. We know we need to do that. All of us need to get in that business. I don't know if you've been inspired by this meeting to do something about it or not, but if you haven't, then probably keep going to the meetings. You will be by the time you leave. But here are some others. Advertising, couponing, and price discounting. I think some of it was mentioned earlier. Do you know how the tobacco industry does with couponing? Advertising and couponing. Advertising and couponing. So you get a coupon, and you use the coupon. What happens then? You get another what? Better coupon. A coupon that gives you a better price, and you use it, and what happens? You get another one. So it is a couponing, the tobacco industry is a couponing machine. And they know that, they assume if you use the coupon, you are what? A user, right? And so they send you another coupon that is even better than the last coupon that you had. So if you haven't used coupons, you have to use coupons because you got to see what you're going to get next and see what the tobacco industry is doing. And price discounting. Price discounting. Did you know about that? Where in the African American or other ethnic communities, the discounts are different. The money they spend on the discounting program, the way they display it, the way they talk about it, the way they promote it is completely different from in other communities. So we know that the tobacco industry spends more money price discounting in our community than in other communities. So the policies that Indiana's got to get to the point where we can pass some of these policies. If you have the ability to pass those policies in your community, then that's what you want to be sure to do. Smoke-free air is another policy, and then taxes. And those are pretty standard policies that you can pass in your community. My time is up, but that's some of the stuff that they're doing in Indiana. Thank you.
Thank you.
Good afternoon, everyone. How are you doing? It's been a great conference or symposium thus far. I want to thank Dr. Brown for introducing me, and also thank you for the invitation to come to talk to you some about the data that we have in Louisiana around surveillance and the youth of Louisiana. I am Takita Ferguson. I also I'm the previous principal investigator and the epidemiology advisor for the state of Louisiana for the Department of Health and Hospitals, the chronic disease program, or the chronic disease control and prevention epidemiology unit for the state. So under that program, I oversee the epidemiology, surveillance and data for asthma, diabetes, cardiovascular disease, oral health, school-based health. And within that, all that being said, the largest area of surveillance that we have going on, and I think some of the better surveillance data is for tobacco. So for the tobacco control program in Louisiana, we have some of the more data for that program in Louisiana. So today I'm going to share some data from the program. I have no financial disclosures to disclose for my talk. So I think that's the title. I didn't say the title. Surveillance gives clues to tobacco prevention in youth. So I'm going to go through just talking about tobacco use in Louisiana, use among the youth, the different surveys or surveillance data they come from. We heard earlier talking about the the YTS, so the Youth Tobacco Survey. So Ms. Gillard, right? She already kind of I felt like she was giving me an intro. So it's going to be some of the same kind of things, thinking about data, but it's going to be somewhat different because it's Indiana up there and then we're down in Louisiana. So it's going to be a couple different takes on things, but of course some of the same messages, some of the same things you already know or very familiar with. So we'll get into some results and discussions, and I'm sorry, I'm kind of a little close, so hopefully I'm not blocking too many people or too much on the screen. So we'll do some discussion and then we'll talk about different suggestions or what we see from the data. I feel like it's almost the data can kind of walk you into things that we need to do in terms of our prevention. So how many people have been to Louisiana before? Oh, right. Oh, right, right. We just had to ask that, see about right, wait. So, down at you, right. Come back for Essence Festival. It's right around the corner, right. So, look at you, Mardi Gras, right? It's past, it'll be here before we know it again. So in saying that, basically it's very, diverse. We have different, it's a unique environment, very unique population, multicultural, multi-heritage, and it just makes a, very unique and diverse population. Louisiana is comparably known for its health challenges though. So it's a fun place to go, but then there are a lot of things that are going on. There are a lot of health challenges. We're ranked number 50. We think about U.S. health rankings. The state of Louisiana is number 50. Last year, before that, we were tied for 49th, so we're still 50th. So, right, because everybody, two states came in 49th, somebody's still 50th, right? We couldn't say we were tied for 50th. But anyway, so Louisiana is 50th. So, of course, we have a higher prevalence of, think about United States rates of things versus Louisiana. Louisiana is higher for heart disease, stroke, asthma, cancer, obesity, physical inactivity, and then, of course, tobacco use or tobacco prevalence. So each day, one thing I was thinking about when you had your 90% up in my slide, I have basically 90%, most of us aware that at 90% of current smokers began smoking before the age of 18. Mm-hmm. So we have 90% of menthol, basically 90% of current smokers begin before the age of 18. That's a U.S. statistic or a national statistic. But within, and also each day, 3,800 young adults try their first cigarette and 1,000 minors become daily smokers. So in that, and when these youth that are smoking, we're talking, when we say youth, I'm talking like 11 to 17-year-olds, and then the young adult population is at 18 to 26-year-old. And they tend to stay smokers well into their adult lives. So we have about 1/3, so that's at 65% of daily smokers began smoking before the age of 18, and then you have the other third began smoking between the age of 18 and 26 when they were young adults. So the youth are really a particular susceptible population to tobacco addiction. So even though we're talking about just being menthol being addictive or the tobacco is an addictive substance, but studies have shown biologically in the youth population that they're more, if you start or initiate usage as a youth, you're more preempt to be addictive later on. So basically that developing adolescent brain is more susceptible and receptive to the nicotine than the adult brain. So you can be more addicted or addicted faster with smaller amounts than you are when you're adult if you start smoking when you're adult. So that having been said, that we need more attention to decreasing the use of tobacco among our youth population. The high burden of tobacco use among youth directly affects our adult population. We're starting young, then we're going to keep smoking, and that's what the tobacco industry wants us to do, to continue to smoke and continue the trends as we go up to adults. After they get us, we're doing public health, and our public health, we're rallying around getting people to stop smoking. We're increasing cessation programs, and we're looking at adult smoking, but the tobacco companies are targeting the youth population to get them to start so they can have new clients and then keep them up until they can be adults. So basically there is statistically significant differences or causal relationship patterns between tobacco use and developing early morbidity and premature morbidity and mortality around tobacco use. Some of these things are premature atherosclerotic plaques, thinking about left ventricular mass, increasing heart rate, all of these things we're seeing in the youth population. You can have increased vascular injury and endothelial damage. You have promotion of inflammation in your arteries, and this vascular injury appears at the initiation of smoking. This starts to happen. And if you see the habit continue, you'll have continued lesions and the atherosclerotic buildup. And they've seen this happen in 25 to 34 years old age. You can already start this cardiovascular disease process as a child, or as young adults are starting to smoke. You're starting to move yourself into cardiovascular disease in your 20s and into the 30s. So the effects of tobacco smoking are cumulative over time. So at an earlier age, you're just shifting the spectrum. Instead of us starting to have cardiovascular issues later on in life in our 40s and 50s, then we're moving it down to a lower age, and tobacco is helping us do that. So in Louisiana, they're experiencing high tobacco utilization among the youth compared to the national estimates. So here we have about 16% versus 10%. So the U.S. Numbers of utilization among youth is at 10%. So in Louisiana, we have about 16% use in Louisiana. So, and about 60% of youth are smokers, but then we go into 30% of tobacco users. So we're talking about, other things. So we can't just look at, cigarette smoking alone, tobacco alone. We have to look at all tobacco use. All, not smoking alone or cigarettes alone. We have to look at all tobacco use together. So compared to other states, high school students in Louisiana have the 7th highest smoking prevalence. So I'm talking about, as you're talking about the top, so I'm talking about the top as in the highest. The 7th, Louisiana is 7th. And then nearly 26 of adults are smokers, place Louisiana in the top 5 worst states for smoking. You're 7th, right? So of course there are several factors that affect youth's decision to begin smoking and continue tobacco use. Some of them include a combination of biological things we've talked about here today. We talked about all of these, psychosocial issues and environmental factors. So of course, in thinking about what's causing us to initiate early, that's how the same approach we have to do as we start thinking about prevention, hitting all these aspects with prevention. So one thing that we have to think about too is this tobacco normalization. Tobacco normalization practices provide information that helps us operationalize these factors across these three categories. Tobacco normalization, definition for it, is basically any practice or variable that seeks to normalize tobacco use or behaviors related to tobacco. It includes strategies employed by tobacco companies that market tobacco as a normal or legitimate behavior. It also includes smoke-free ordinances, perceptions and attitudes around tobacco use and peer influence. So what am I saying there? And this kind of formal definition is some of the things we were talking about earlier, just normal behavior. Like if we make it so it's, it's okay, if we're not put here the ordinance piece, if we don't have any policies against it, then it's acceptable. If we allow it to happen, then people think it's okay. If we see it happening, it's okay, so we kind of condition ourselves. Or is this a society norm? So we think about just norms. So that's the same thing we're talking about here, just what's our society norm, or what's happening, what's acceptable behavior, what's okay. So we're talking about the tobacco normalization. We've heard that term earlier today. Think about tobacco norms. So in looking at these factors and figuring out how to better understand what's influencing our youth, we look across different survey methods and we're looking at Louisiana data. So we're looking at the Louisiana Youth Tobacco Survey, the YTS survey, and we're focusing on the 2012 data for that survey. And the YTS, that's one of the pieces for the tobacco surveillance in New Orleans or in Louisiana. We also have the adult tobacco survey. Of course, we have some information going from the behavioral risk factor surveillance survey too, but it's not as in depth as the YTS survey. And I have some other figures that I'll end up talking about that come from the BRFSS survey, the behavioral risk factor surveillance survey. But the Louisiana, here I'm abbreviating the Louisiana YTS, so if I just say YTS, I'm still talking about basically the same survey. But it's the sampling design for the YTS is a 2-cluster sampling design. So they're pulling across the state. So they're looking across all schools of the state and then looking within all schools and then within students in the classroom. So we think about 2 sampling designs. So data coming from the YTS is is weighted. So they do a sampling scheme so you can say, or you can make, have the data applied for the whole state. So of course you're not necessarily sampling everybody within the state, but how you're not everybody in the state is not participating in the survey, but the data from it allows you to say things about what's happening in the whole state. So we can say, as we were saying this morning, that, Dr. Gardner was saying that is there an issue there? Because of course a lot of the data that I'm talking about today is CDC data. So some people still question, or if we get down on the ground and look at it, or if we have a survey that's really looking at a closed community and just focus on that community, are the numbers really different? But I'm not dealing with that today. I'm doing the YTS today. That's the CDC. So it's not necessarily a disclaimer, but it's acknowledging the fact that this is more of a bird's eye view, but we are talking to students, that we are asking them questions, we are going into the schools, and that's one of the best places to be able to capture them. So in that, in Louisiana, with the YTS 2011 survey, they asked 40% of middle school students or 40% of middle schools to participate across the state. That was a sample frame, and about 24 of them participated. And they asked 30 high schools, and about 23 of them participated. So it was about a 85% participation rate across everything, including schools and students. But if you do it all the way down to the student perspective, it was about 68% participation rate across the state looking at it. So that gives us about, and there was about 1,400 high school students and about 1,000 middle school students participated in the survey in Louisiana. And in Louisiana, this 2011 survey was the third time Louisiana has done the survey. So this is the first time that they really could show trend data in it. So we're kind of a little late to the game. Being number 50, it's like we have to step up around, even though I said this is the better surveillance for Louisiana, there's still a lot left to be done in Louisiana for data, for surveillance. Because Arkansas, they started the YTS in 1999. So Louisiana started in 2008. Louisiana started 2008, 2009, and 2011. Basically was the last survey that they have and the data that's available. So within there are 72 questions on the survey addressing students' use of various tobacco products, including cigarettes, smokeless tobacco, cigars, beaties, black and milds, and hookahs on our survey. And you heard that earlier when we talked about the Indiana survey. So it's based, there's some core questions that appear kind of state, nationally for the CDC, and then the individual states can add questions to the survey too. So for our respondents or in the population for Louisiana, of this 2,400 students, we see we have about half Caucasian and then the other half are minority. But I've broken out that minority, and that's how it was sampled. I've broken out that minorities that we can actually see how many were African Americans, and then we have the other category. So the data that we did the report of, we still keep the other categories separated out, but that data is not as reliable because the sample wasn't given to really have a great enough numbers to be able to have those numbers be credible and significant for the population. But we will see some differences with the other African American population. But most of my slides, or the things I'm going to point out, are looking at differences between African Americans and Caucasians. So we see it's about half male and female, and then the high school is a little bit higher than middle school, and we still see about almost 30% usage of tobacco in the state among this age group. So we're talking that in the high school, middle school to high school group. So one of the variables that we want to look at in using data is this idea of susceptibility. And this is a term of think about how susceptible you are to start smoking. So there is some CDC have used this term, and they define it with really two pieces of information. How would they accept a cigarette from offer from a friend, and then do they plan to start in the next 12 months? So these are the two pieces of susceptibility we look at from a CDC definition. So how we broke it out across three, basically ever smokers, what you think? Smoke at least one combustible product, and we basically lump all combustible products in here together. That's an ever smoker. So susceptible is basically they haven't smoked any of the products, but they would do these. So that makes them susceptible, meaning they would take a cigarette from a friend. This is them self-reporting, or that they plan to smoke a cigarette for the next 12 months. And then the non-susceptible group of basically they're not a smoker and they wouldn't do either of these two things. So in this thought process, if you're susceptible, so this is like the version, the next, they're going to move into the next people that are ever smokers. So this is a population which we can target, and this is a place where we can spend time on trying to make sure that they never get to this group over here. Maybe they can stay here or they move to this group where they have no desire to start, to initiate smoking. So another variable, and something else we were trying to look at is a normalization. So I talked before about what normalization is, and normalization is a large concept, so you can't just define it with one thing alone. And often you're using different variables or different questions to identify or to collapse it into a score. Basically, I've left these out, but looked at these in conjunction together. So these are questions that appear on the YTS survey. Do you think smoking makes people look cool? Do you think smokers have more friends? Do you see tobacco use on TV or in the movies? Do you see advertisements for tobacco on the internet? Would you use or wear products if it had tobacco company's logo on it? Or do you think tobacco companies mislead youth? Do you guys care to make any ventures or guesses of what you think our African American kids or what African American kids said versus white kids, or what children today are thinking?
I think they're going to say that they see it on TV and movies more than what we realize.
Okay.
I think they wear a tobacco company logo.
You think they wear a lot of logos?
Yeah.
Right.
Because they give away.
Right. One good thing though, that most schools now, I mean, but you know, that kids will spend a lot of time outside of school, but schools, they can't wear the logo products. That's a part of the policy on campuses, or it should be. Something, do you guys see how that these fit into normalization, making tobacco kind of acceptable too? And that's what they were chosen. So, of course, won't bore you with statistical analysis, but being an epidemiologist, I have to say it wouldn't be right for me to present data and not say that I am methods. But anyway, of course, chi-square, novas, and we have some logistic regression too in there. And I've used it all with SAS, and when we talk about statistical significant difference, I'm talking about an alpha level of 0.05. So this is cigarette published among youth in Louisiana in 2011. So from the YTS survey. So this is the same number I talked about before, the 16.2%. If we look here, we see African Americans are down to 10.7 and Caucasians are at the 20.1. So when you first look at this, you're like, oh, okay, well, maybe we're not doing too bad. It's at 10% versus 20%. So we're doing half of what the other groups are. And of course, this is that other group where we have so low numbers, but still, it's something as a state that we do look at, even though we can't necessarily, write home or publish a lot on it. We always have to put a disclaimer about the numbers there being so low. But we have to, of course, watch this number because this is another population that's going to increase too, or the potential is to increase. We see here that female to male, that males are smoking more, and it's true. We have about, I think it's 1.3 or like 30% more likely for African American men than African American females to smoke cigarettes as well. So let's look a little bit closer. So the prevalence of tobacco use in Louisiana overall. So the previous slide was cigarettes alone. Cigarettes alone was the previous slide. So now this is really any tobacco product. So go to this end of the slide. So we've moved from 16% to really a better picture of really almost 30%. So we're at 28% usage. So we think about any tobacco. So any tobacco includes all of these products. So we can look at combustible alone is at this 25%, and there's no real black and white difference with combustible products. When I say combustible products, we're talking about cigars, BDs, together and cigarettes. So all those are going to combustible, so things to burn. Here, cigars and cigarettes are black and mild, about 18.3%, and I have the next slide which will break down that and the BDs. So smokeless tobacco, they're more Caucasian, the numbers are higher among Caucasian smokeless tobacco. And probably you think of that, you think about it almost to kind of guess it, but it's still true. What the data shows the same. So this is for cigars and black and mild prevalence. So what's happening here? Before we were lower, right? So now we're 21% versus 14%. And this is a cigarette. So some of the same things you were seeing in Indiana. So here, for BD use, African Americans double that of Caucasian. So there's 7.5 and 3.5. The other, you see, got to keep an eye on that. That's pretty high up there. But then we got to focus today about African American versus Caucasian. So it's double. So problem, right? Our CDC is saying it. We're hearing it. We have things coming out. New warnings thinking about just the combustible, not the e-cigarettes, these vapors, and all the dangers that are in the vapors. But I definitely want to put this in because we're not capturing this right now with YTS survey. So the data I'm showing you is leaving out the e-cigarettes and this thing we're saying is phenomenal, this thing that's growing in the abuse population. Of course, new things, it's electronic. There are a lot of things that can be very attractive about that e-cigarette that, for a youth population. So we're going to have to count those very soon. We need to start counting it. And then that's the same. It's funny when I saw him posted this one, I was like, I have that same one in there, right? So why could switch? So we are trying to switch people over to that. So of course they're going to go too. They make them nice and colorful and all different kind of fragrances. Methods or flavors, should I say? Methods for buying cigars by race. So this one kind of breaks out how they're buying cigarettes. But we have to first remember, right? It's not legal to buy cigarettes. So there's it's going on by FDA. It's not legal for them to do this, but what's still happening? So despite the law in Louisiana, they continue to be able to do the biggest thing is that they're buying cigarettes. So for our state, clue to something we can do is better regulate or better, it's like enforce policy that's already in place as in them being able to buy cigarettes. So we have the leading thing is buying is store-bought cigarettes. The next thing after that is barring or bumming cigarettes from others. So, and then this bumming, we're not sure exactly who they're bumming from, but more than likely it's people, their peers.
But they're at the store.
Right, which is that,
They're
the
bundled.
one, but for the body, right, but, right, the other people, the rest of them, right, their friend involved, they got in, the friend looked older maybe, but, they know the spots to go, and then that's the other thing too, people know where to go and they won't hard, they won't look.
I sell Lucy's.
Huh?
I sell Lucy's.
The Lucy's, right.
Those are the ones.
So, right, the Lucy's, the individual cigarettes, where you pick it up. Vending machines are also, it's basically Lowe's. If you see, vending machines is like, they put them in place, they're really only legal places where, that are regulated by age, like where they have video poker machines or casinos, where you have to be a certain age to get in anyway. It's the only place there's supposed to be vending machines set up. Give money to someone else to buy. I have a person 18 over gave it to them. They took it from the store family. So this means basically they didn't purchase it. They like right. They stole it, or they just took it from family members' purse or something. It wasn't given to them. They just took it. And then this is just other way that they completed on the survey. So in that susceptibility groups here, I should have been better if I put in for percentages. But for group that susceptibility, the definition I gave, really the overall, this group that falls in here, this is about 18% overall. So overall, among the youth, we have about 18% that fall into that susceptibility. So if you think about, these are people that are saying, basically, in the next 12 months, I'm about to smoke. They're like telling you, hey, they self-identify. And we think before this morning about all of our data, it's a little underestimate of what's really going on and what's the real picture. So in white and black, that's for whites it's about 20%, and blacks it's at 143, it equates to about 17%. So about 17% of blacks fall into that susceptibility category. So putting these and think about a regression model, think about somewhat predictability, looking at susceptibility versus these normalization variables is what this slide is about. And I'm just going to point out a few of them. Here it actually says results from female multinomial position regression model. This is actually from the males. I have the female by replacing the gap and change it to the male population. So in the for males, those that are susceptible non-smokers, that susceptible population, I'm just going to focus on them versus the ever smoker. The ever smoker is kind of there to kind of look at people that are smoking. What are their thoughts about normalization variables? So basically 50% appear this didn't really reach statistical significance. So of course we put kind of more weight and thinking these numbers are really more true than the ones that don't have a star eye. But here about 50% more they think that that they have more friends because they smoke. Here about twice as many people, the susceptible group think it's cool to smoke. So in that, and also those two variables, African Americans versus whites, they think that they have more friends. That African Americans think that more than so than whites, and African Americans also think it's cooler to smoke than white from the data. So here we think, seeing it on TV, they see it on TV, that's double as likely here. That's saying that they are less likely to see it on the web, about 60% less likely to see it on the web. We see the logo is a big indicator, right, on the mouth. So just seeing it, just their product placement, right? Or that they will wear this and they will take it. Think about, kids like we like free stuff, right? Right. We like free, our kids like free, right? Another t-shirt, or sometimes they're just trying to be cool or want to look older. So they're going to what?
The snapbacks, the hats, they call them snapbacks.
I'm not even up on my lingo. What's the snapback?
It's a hat that's snapped in the back.
Okay, it's a bib too?
Yeah. We call it a ball cap. They call it snapback.
So, and then they have like little bags and water bottles, right? So, so this is getting into thinking about just beliefs behind it. So, knowledge and beliefs in our youth, and the YCS gives data around that too. So this shows us that 20% of African Americans think that tobacco is not addictive. Right, 20% think. Right, versus Caucasian at 12.5.
That's where education's about.
Right. So here they believe, we have about 16% believe that smoking 1 to 5 cigarettes a day is harmless. So like, 1 to 5 cigarettes a day is harmless, right? So here we see about 15%, almost 16% believe other people's smoke is harmless. So in this day and age, as much as we talk about environmental hazards and ETS and secondhand smoke, they don't understand this. So basically in knowledge and beliefs, and then overall, students who smoke or who are susceptible to smoke are more likely to view tobacco as a normal, as behavior is normal. So that susceptibility group, they're most likely to view tobacco behavior as normal. Prevention campaigns should promote messages that portray tobacco behavior as aberrant. What I'm saying is like we should show, campaigns like this is not normal, like changing the norm where it's not okay. So as marketing companies are marketing to them that it's okay, our prevention things need to market saying it's not okay, and they need to see themselves in the prevention ads. If the marketing and the media is smart enough to show them their pictures to get them to use, we have to show them themselves and getting them not to use them. So denormalization measures should target youth, is what I'm saying, by their susceptibility use and provide each group with unique interventions. So we should think about, friends or maybe, different ads with groups of friends in it. So what else? Here is summing up in discussion. Other things I thought about was around just in environmental tobacco smoke that I didn't mention before. That the CDC basically anyway, at this point they don't have studies and a lot of data that actually have shown a dose response in terms of tobacco smoke and cardiovascular disease in some pulmonary. But because there was a RFA out to look at dose response in. But so at this point that we know from data and we're at and CDC stands behind it that no level of environmental smoke is safe. But we just don't have numbers or saying like, 0.0 this, lead to this many deaths, but we know that it leads to death and that it is a negative. But youth are unaware that of that environmental hazard and the environmental smoke. When 25% of youth smoke some type of tobacco product, and this is 25% of African American youth smoke some type of tobacco product. Also, in the YTS, smoking initiation has remained similar over time. This 13 to 14 years of age category is shown from the 2008, 2009, 2011 data. It's the same time for initiation in Louisiana among youth. This 13 to 14 years of age is the time that they're initiated. And for girls, we're seeing actually it's 11 to 12 is the age category of initiation. But with this same kind of error suggestion, this is showing us that there's some social norms going on, making it okay to start this time, but there's some things that are environmental pieces that are helping them initiate or not necessarily swaying them not to start smoking. So here's where I was thinking about the environmental smoke. I have about 1 minute, so I'm going to go ahead and make sure I wrap up. About 53% of youth have been in a room with a smoke at least once in the last 7 days. So our youth are being exposed to tobacco smoke. And I know in Louisiana, there is law where you're not supposed to be in a car or vehicle with a child with smoking, but then how is it being enforced? The same thing, they're selling products in the stores, they're not being able to enforce them riding in the car with them either. Many students are illegally purchasing cigarettes from stores. Most popular methods was bar and bum, at least like the method requiring cigarette use of the vending machines. So that's just wrapping up. So this is other pictures of smoking. I'm thinking about tobacco companies are targeted through media. Look, you guys are looking at the different types. Right. These cigarettes, these are BDs. Everybody's here in kind of tobacco, so you guys know what BDs are, right?
That's one of my questions.
What?
What is the BD?
Not all of us are. This is not my arena. So I'm trying to look at all of them, see if make sure I recognize everything that's on there.
One of those slides I had in the beginning, I'm going to my question time, showed a bunch of different colors too. So I'll flip back to that in a second. Because it almost looks like candy on some of the slides that can show you. Right. And they can. So so these are the BDs. So sometimes these don't even have a filter in it too. Sometimes they're clothes products being sold too. So it's just other, smokable, combustible pieces that are put in here. So it's tobacco mixed with other things or other leaves. So the BD, right? So this is a BD. Okay. Right. So sometimes it looks like a cigarette. Then you also have some mini cigars. We saw them earlier, but there's some mini cigars that
Swishers.
Swisher Sweets are just they don't really call those mini cigars. Okay. Right. It's just they're skinnier, longer, and they have a little pipe tip on them. I don't have one of those on here. But Swisher Sweets are not necessarily considered a mini cigar, but they have them. They're basically same as a tobacco and rolled the same way, but they're smaller. But more of the bees have a different kind of clove or different leaf inside than just tobacco. So the social ecological model, we have to approach it this way. So thinking about that, we not just at the individual level, but all of these things are interplaying to what we can do and how we can target it. So thinking about knowledge and attitude. So of course we need to increase knowledge around, for our kids, around the kids. we need to think about the interpersonal, the family, friends, and social networks. So think about then also in school, to the organization, all their friends at school, what they're being exposed to. Also think about at school, we had about less than 29% have ever heard of like a Say No campaign around tobacco smoking. So we're kind of losing those pieces within some of the school systems of giving them other avenues or other tools for them to be able to say no or to go against it, kind of fighting that normalization piece. So organization includes the school setting. If you think about it, school doesn't only give them their academic teaching, it also gives them their environmental base and environmental teaching. So we have community, other things that we're doing, and then public policy. Of course, in tobacco, we often do a lot of, we've seen much success with the policy piece. So this is my last slide of information. Basically, we've kind of talked about this. This includes the suggestions of what we can do. Think about trying to delay the initiation of tobacco, enforcing laws around it, and making sure we still need education and targeted programs to the youth. So acknowledgements for the Louisiana Department of Health and Hospitals, the Chronic Disease Epidemiology Unit, Eva Rickett, also the program coordinator, program manager for tobacco control program at the state, Brandy Bourgeois. So my references, and I'll take any additional questions in this session.
One of the things that I have truly enjoyed about the conference is that it has been data-driven, research-based. We've gained a lot of information, and today's presentations have given us information about what I came to hear about our students in public schools. What are our middle level students doing? What are our high school students doing? We've heard from two presenters in several parts of our country, Indiana and Louisiana. So I'm going to invite them back to the front. And now you can continue with your questions that you had, and there's a hand in the back.
Hi, my question is for Dr. Ferguson. Okay, I have a question because what you were talking about with the susceptible group, to me it calls to mind a theory of planned behavior where you have that group that's more ambivalent, so to speak, and that intention really is the best predictor for starting a new behavior, right? And so when you're looking at normalizing the behavior or normative beliefs, what are some of the program campaigns that are taking place in Louisiana to kind of make the positive behaviors more normalized than some of the negative behaviors, the images to combat the images that we see on media and things like that?
There definitely can be more in Louisiana. For the last year or so, they focus a lot more thinking about policy. A lot of the money and the dollars that are coming in are really focusing around policy for Louisiana, because Louisiana has been dragging their heels, somewhat kicking and screaming, just to get us to to ban smoking in public places and restaurants. So for some of the youth, it's not as much as it could be. They're doing some high school programs. They're giving money to high schools to come up with some of their own programs that are there, but there's really not a lot to necessarily fully change around. But it's more the clubs and the groups that it's doing.
I was going to add just a basic theoretical answer to your question is in tobacco control, we say that there are three things you have to do. When you look at the states that have the lowest smoking rates, and this is adult smoking rates in this particular case, but adults model what happens with the kids, it's a strong tobacco control program, a strong statewide smoking policy, and a high tax on tobacco products. And when those three things are in place, the tendency is that the state has a lower smoking rate. If those three things aren't in place, like Louisiana and Indiana, then your smoking rate is high.
But they go lowest tax rates.
Pardon me?
They go hand in hand.
All of it goes. There's no one silver bullet. There's no magic wand that you can wave and one thing that makes it happen. Yeah, when all of those things exist, when those three things exist, then the state has a lower smoking rate. And we don't have them in Indiana, and neither does Louisiana. We have a cigarette tax that doesn't even tax the other tobacco products. And ours is
Coming over to Indiana, trying to
they might be coming over to Indiana.
I'm from Chicago.
Yeah, they come over the border, but ours is only 99.5 cents, and it's a cigarette tax.
Right,
Yours is probably lower than that.
I think ours is lower.
Yeah, I bet yours is lower than that.
Any other questions. Somebody mentioned earlier when I had to decide about media, and we have about, like, our data showed about 70, I ended up saying about 73 to 74% people, you know, of see it in the media, or report seeing it in movies and seeing it on television, tobacco abuse.
Even music videos. I mean, if you think about it, one of the things projects I do with my students is we go and I get a stream and we sit there and watch YouTube videos on the small camera. And it's unbelievable, the music videos. And it's every genre of music. It's not just one, it's all of them. We actually did all of them. And if they're not using tobacco, then they're alluding to using tobacco. Where Miley Cyrus is, I think the students had the hot dog. She was like the hot dog in her music video. And they're like, we had to watch the video 3 times to just make sure. They're like, I swear it's a big cigar. I said, I watched it before we. If it's not a tobacco product, then they're alluding it to, so they are into it.
Yeah, that stuff works too.
What grade begins your middle school?
6th grade.
6th grade.
I just wanted to ask, is it hookahs or are they legal?
Yes.
I just didn't know.
Yeah.
I was thinking they were
They all
street
be
legal.
illegal, but they're legal.
Yeah, right.
And they have restaurants in,
They have what?
they have their record in a restaurant.
Yeah, they're multiple.
They can't have it in a
restaurant,
restaurant.
you can smell the hookah.
We can't.
And the bad part about it is, you know, people that say that they're not smokers visit those and use their package. You have more of that, you know, college educated crowd, college students that are using that young, you know, professional groups who are visiting the hookah bars. So, of course, in some of the bars, there, you know, might be like an age 18 restriction, or you're talking about like a age 21 to be able to get in because it's a bar, because they sell drinks too. But some places don't necessarily have that, or you can get our own man. It's more clubbish, so you can get in under the age of 21. You have, you know, access. So if you don't really, you know, have the ban where 21 drinking age should be on it, then you're going to have high school students that are potentially visiting these as well. But I think it's an area that, I mean, we need to count. You know, we need to count more because, I mean, the process alone, depending on how they regulate it, it's a public health hazard because there's a reservoir of water in there and it could breed like tuberculosis.
Right.
There anything that can be circulating in the water, but some places go that, you know, we change out water, you know, it's like a whole little, you know, that they're supposed to be like fancy or upscale, you know, like you can go and purchase and pick out your flavors of different tobacco products and you can mix and add, and then you have your own little setup. So it's become this, you know.
And in Indiana, in Indianapolis, it's not all over the state, but in the capital city, we can't smoke cigarettes in hookah bars. That was one thing that passed, as if it made a difference. Yeah, it does. But, you know, that was one thing we just passed. I mean, and my point is that we still have so much work to do, that we tend to think we've done something when we do that, when in fact we've done nothing.
I have a question in there.
Has any of your work been tied to like the way males kind of come of age and then it's a symbol of manhood to then adopt smoking, or even if it's just socially because of their status as a man at that point?
I think I didn't bring any of it with me, but some of our ethnic marketing pieces speak to some of that. And the way we did it, the one that comes to mind when I hear that question is one that shows it has kind of a slavery connotation to it, meaning that if you start using tobacco and it's directed at African American males, that it's like the product enslaves you. You become a slave to cigarette, trying to kind of get at how they're thinking about it. And that's close to maybe what you're saying. But we've done a few marketing pieces when they're targeted at the African American community that try to get at a male's an empowerment attitude, or I can do what I want to do, I'm a man now. But it's hard. It's really hard. It's hard to target market, and then it's hard to get the pieces to them and get your point across. You have to work very hard on the ground to get that message out.
One positive things that we saw in the YTS is on a different note is that more African Americans want to quit. So in that youth that are looking, the numbers are higher for African American youth to want to quit versus the Caucasian. So we have about 7% of them want to quit versus a 48% in the Caucasian group that say that they want to quit.
One more question, then we'll end. Go ahead, yes.
My question is basically a follow-up question to the African American smoking prevalent rate as they get older. And we had some suggestions on why we think that could possibly be happening. Why? One of the things I would like to propose, and I've thought about this, in addition to the rite of passage into adulthood, and I'm my own person and moving out of mom's house into my own place. In addition to that, adulthood for African American men, and I think about our social structure in this country and the skin that African American men live in every day, the social stressors of life, and I know sometimes that may be difficult to measure, but how much is the back, we know that African American men are more likely to drop out of high school when compared to other groups, and we know that a high prevalent smoking rate comes with low education attainment. But there are so many other things socially and economically that go along with living an African American male life in the U.S. and how much does that contribute to the increase in the smoking prevalent rate?
I don't know if it's been
coupled
studied.
with all of the other
I don't know if
things
it's been studied, but I agree with you, and I think the tobacco industry capitalizes
so,
on
too.
what they know about young adult
That's my
African
suspicion.
American. Yeah, and they just target market toward them based on
what they know.
all those different things.
It's unfortunate. I bet they have it in kind of information.
Oh yeah,
But I just believe there's something there.
I do too.
But here again, as Dr. Williams said this morning, not what you believe, what we know. But I strongly suspect that's an element.
Yeah, we're going to have to look, I think we're going to have to study, we're going to have to look at it and try to figure out what is it that we can do that keeps, even though we start later, that keeps us from starting later, that bridges that gap between high school, at least in Indiana, high school, and then young adulthood, because it skyrockets in young adulthood.
Thank you, Mrs. Gillard and Dr. Ferguson, and thank you.